So my hospital did a webinar town hall on February 27th from the medical director of infection prevention and control, one of the senior nurses in infection prevention and control, and one of the heads of emergency planning. And it was an interesting town hall. So this is edited highlights from it. This is part 2, and I interject my own views on it. My views in no way to be taken to represent the people speaking, nor the hospital, nor the Ministry of Health of Ontario. But I do think it's worth looking at parts of what was said and actually discussing it.
Can you talk about our current PPE recommendations, and will this change if a pandemic is declared?
The standard recommendation is to use droplet contact precautions, which we use for other viral respiratory infections, and that is our best protection against COVID-19, and it's what we use for influenza, for example. The exception being, of course, when we are doing so-called aerosol generating medical procedures, what we call AGMPs, and those things that include intubation or non-invasive ventilation. There's a possibility in that situation that we can aerosolize the droplets and they can become transiently airborne. And so in that situation, we enhance our personal protective equipment to the addition of an N95 with face shield rather than a surgical mask, or I should say a regular mask with integrated visor. And right now our guidance is the same as it's been, which is the standard PPE that we've been talking about with the N95 for the care of patients that are identified as persons under investigation. One of our concerns, and I'll just be very transparent on this point, is related to the sustainability of the current approach. And again, those discussions need to happen at the level of ministry, but you can imagine a situation where you have a large number of cases that come in and we're saying that we need N95 masks and negative pressure rooms. That's just not going to be sustainable for the numbers of cases that we're going to be seeing or we expect to be seeing.
Of course, that's true. You can't sustain N95s when you haven't got warehouses full of them and you're not manufacturing in your own country if there's a global pandemic and there's a massive demand for them. But it is a huge pity that we don't have vast quantities of these masks stored up, because we really should have done. Whoever's responsible for pandemic planning provincially and federally in Canada has really dropped the ball.
We currently screen for 12 countries. How will we decide whether to add more?
It's a great question. And so, as we've mentioned a few times, we're still in the containment phase of this outbreak while we're obviously preparing for the pandemic and have been doing so for some time. And so in the containment phase, we've been very proactive at Sunnybrook at adding additional countries of concern so that we have a broader net, if you will, to identify patients. It's actually thanks to that mechanism that we were able to identify our latest case earlier this week, and that was because of our proactive approach to this. Right now we have 12 countries, and we added, I think Italy was the last country at the end of the weekend based on the situation evolving there. We may add more countries to that list day by day. And of course, as we're doing it, we're ramping up for the pandemic preparedness because obviously that will become the reality at some point.
Not very reassuring, is it? Countries are added after they've had widespread local outbreak. Before they've had widespread local outbreak, it's been widespread within that area and those people are travelling hither and thither. So that's why, whilst we have air travel, there will be no containment of this in areas. There will keep being outbreaks across the world, and that's what we're seeing. Further and further spread. I think we're over 60 countries, not 12 at this point. But again, if you have one case, why isolate them? But then one case can become, over a weekend, nearly 1,000 cases, like happened in Italy. So there is an argument, I think, that we should have stopped air travel quite some time ago. I do personally think right now, it's a bit pointless. It's in all of our communities and it will spread.
Can COVID-19 spread without symptoms? If so, what are we doing about that? Should we screen people just for travel history and not symptoms?
We are still learning about COVID-19 and we have to certainly respect, pathogens that are new. We can draw from a lot of data and a lot of research, and there's a lot that we know about novel coronaviruses from the previous ones that I mentioned about. For COVID-19, we still don't totally know the answer in terms of how infectious or when people become infectious. It's very, very clear, though, that there's a spectrum of patients that are certainly very well have very minimal symptoms. Some of them may not even acknowledge their symptoms fully. They might be what we call subclinical. And it's possible that those individuals certainly could pose a transmission risk, but it's actually not clear. And I will say that what we do know is that the people who have higher viral loads, and remember it's the viral load that poses the highest risk of transmission, tend to be the people who have the more obvious symptoms. And so I guess to answer your question, it comes back to the approach that we take to the syndromic screening that we do all the time. It's very important to be very diligent with that in terms of, asking patients specifically obviously about fever, respiratory symptoms. And I think the only difference here, which is normally we would say, oh, you don't have a cough, you don't have shortness of breath, that sounds like you have no respiratory symptoms. It just takes an extra probe to be extra diligent. Some patients have very mild cough that they may not necessarily endorse at first pass, and really just having a low threshold to make sure we're using the appropriate precautions. So I think that's the best I can answer that question. We don't think that there is asymptomatic transmission.
Obviously, if you believe yourself not to be sick and if you believe you have no symptoms whatsoever, you won't make any efforts to quarantine or protect the society around you. So whether they can poke around and think, yeah, maybe you had a cough in the morning but you didn't realize it, or maybe you felt a little short of breath on the stairs yesterday, to classify that as there is no asymptomatic transfer, I think is a huge reach. I think it's designed to make people feel comfortable, but I don't believe it. I do believe people can infect other people.
Under what circumstances is a patient with COVID-19 sent home? Is it because no treatments are helpful, or is it because treatment isn't necessary?
We know that the majority of individuals with COVID-19 will have very mild symptoms and actually, frankly, don't need to be in hospital. And, we always talk about if you don't need to be in hospital, then you really shouldn't be because of the risks. That's so true here, because if you think about it, if people are coming because of concerns of COVID-19, but they don't need to be here, it just increases the crowding, the overuse of resources, and the risk of exposures and transmissions, even among people who have mild symptoms. So we really want to keep them, away. And so that's a bit of a public health ministry community issue. The way we're dealing with that is basically we're as soon as we have tested someone and they've been assessed, if they're well enough to go home, our preferred option is they be discharged. But in a pandemic situation where you look at the larger number of cases, so it's a bigger pie, that small fraction that are very, very sick just becomes a more significant burden of patients.
Of course, that's absolutely true. Hospitals can really infect people and kill you. And also, if you have all these people crowded together, they can spread it. But you'll notice he never actually addressed the question. There is no treatment for COVID-19. What we can offer, limited, is life support, ventilation and chest physio and IV infusions and inotropes to squeeze the periphery when they're in septic shock. We can't do that for large numbers of people. We can't do that for a large number of people.
What are the risks to non-clinical staff who are not trained in IPNC procedures and protections? Do those of us who are support staff working in the hospital need to be aware of any special requirements or protections to ensure our safety?
One of the important things to know is that none of us, all of us are trained in the basic fundamentals of infection prevention and control, and that includes cleaning your hands. Hand hygiene, use the hand antiseptics or hand washing with soap and water is still your best defense against protecting yourself against this and any other kind of viruses. I think another important feature to remember is that the portal of entry is really your eyes, mouth, and nose. And so remembering that even in the absence of hand hygiene, keeping your hands away from your face is really important in protecting yourself. Your risks in the community as we go into a pandemic state is really high, and just knowing and adhering to these fundamental basic infection prevention and control principles will really work to keep you healthy. Inclusive of that, remembering to stay away from people that are actively coughing and have respiratory symptoms, at least a 2-meter zone. That is another important infection prevention and control measure to remember.
That's great advice. What the staff are asking, the cleaners and the porters are asking, is what special equipment, what special masks are we going to get and are we going to be able to use? And quite clearly, none, maybe surgical masks, maybe none, depending on availability. What people do need to have is clean shaven faces and N95s, and even then not to touch their eyes, face, hair, clothing, wash their hands with soap and water for 20 seconds as frequently as they can, and to be very aware of the fact that whatever you've touched, somebody else has touched, and you might then transmit it to yourself.
Hand hygiene gels are becoming very hard to come by in commercial outlets. For personal use, is there any value in using isopropyl alcohol or 3% hydrogen peroxide as a substitute? Are there any other substitutes beyond hand washing with soap and water, which isn't all that accessible all the time?
Truly, as I mentioned, if we can keep our hands, if we consider them to be contaminated, away from our face, that's one way of preventing this illness from spreading. When it comes to other kinds of products or hand antiseptics, use of alcohol-based your 70% isopropyl alcohol that you find. Some of these solutions are not intended for hand hygiene because when you put them on, they evaporate very quickly, or you don't have the right amount of ability to contact time, or that ability for it to stick to your hands. And contact time is still important, so I don't want to give anyone the false impression that applying some liquidy alcohol onto your hands will actually be sufficient. So I think if you're in the public and you don't have access to hand washing or hand antiseptic, the main thing I would suggest is to keep your hands away from your eyes, mouth, and nose. You can, the World Health Organization does have ways of preparing different kinds of alternative hand hygiene products, but I think it gets kind of complicated. So just remembering the basics and sticking to the basics will really keep us safe.
No, it won't. You really do need to wash your hands with soap and water for 20 seconds. No rings, no watches, no hairbands. Now, she's correct. Alcohol, it has to be 60%. They're saying 70, but I would go for 70 if you can, but 60% or higher alcohol-based solution. Now, for example, a lot of people talk about using vodka. This is not vodka. This is a beer vodka from Canada, and this is about 43% proof. So when I put this on and rub it on, I think I'm actually sterilizing my hands, getting the viruses killed, and I'm not. So if you have a weaker alcohol solution, what I would suggest is doing it twice. So washing your hands twice. The other thing as well, if it's evaporating, keep adding it. So you've done a minute, okay? That's one thing you can use. If you have a specific product like this that is actually designed to do two things. The alcohol, it's ethylene alcohol, and it lasts, and you can feel it wet, right? And you can feel it working, you can feel it's wet. It actually does two things that are great. It makes contact time on the skin up to a minute, which is what you need to kill the virus. It also adds a layer of skin protection. Your hands are going to get really, really chapped, which is why you also want to get yourself a really good hand cream as well. You're going to be washing your hands with soap and water as much as you possibly can. You're going to want to use a gel, commercial product, like alcohol-based solution, every single time you've touched something somebody else may have touched. Yes, don't touch your face, don't touch your hair, don't touch your cleft, don't do this. Just don't, okay? Not with contaminated hands. Make sure you've sterilized your hands first properly. And that's going to be very, very difficult, especially when you're tired or you're stressed. So you've got to slow down and think about what you're doing in the public sphere.
Our advice here is just slow it down. I know we're busy. When we work on the ward, we're trying to do things, but we need to slow it down and make sure we doff our PPE appropriately, right? To avoid self-contaminating, and make sure that we clean our hands diligently, and again with the contact time that Natasha mentioned.
So far, the message we are getting is that we are not at risk. While I appreciate the sincerity and the response we are getting from the IPNC teams and medical teams, this differs dramatically from what we see in the news. What is the current risk level?
Heard us communicate on this topic, you may have heard that the risk was low. That was true then, and it has been true until now, because there's actually been no locally acquired infections in Canada. The risk of getting COVID-19 on the subway has been very low to virtually zero, and we've not even identified any of those cases until now. But the reason we're doing this virtual forum now is that that risk is changing. And so this is what we are saying, is that that risk, although it's not high right now, we still had no locally acquired cases, it is rapidly evolving. And we would not be surprised if there were locally acquired cases of COVID-19 in the not so distant future. You know, the risk in other countries, for example, is certainly very different than our own, but we're talking about the reality in Toronto, Ontario, where it has been low all along, and we've been very well successfully managing the imported cases, containing them. That continues to be true, but now we're having a conversation about what we're expecting. We were hoping it would be contained internationally. That has not happened, and now our message is the risk is actually going up, and this is why we're having the forum today.
There you have it. The risk is low, the risk is going up in Toronto, Ontario. And I think it's a very different style of messaging from what you're probably seeing from the mainstream media. Remember, this is directed at a wide hospital audience, including people who are actually cleaners and porters. It's not necessarily aimed at professional nurses or professional doctors. This is aimed at everybody. You need now to learn how to wash your hands. You need now to learn how to not touch your face. You need to learn now how to actually get 2 meters away from people in a crowded store. You need to now know how to spot people who might look a bit flushed, who might look a bit pale, who might look a bit sweaty, and make sure that you are not physically getting close.
Can you talk about the number of cases that have been reported globally and the current reported fatality? Is it accurate, or is it possibly higher than what has been reported?
At the moment, there's the data that's reported, and there's what's actually happening. And when we talk about surveillance and epidemiology, we have to interpret some of the numbers with some important cautions. So first, I'll say what the numbers say, and then I'll explain a few of the caveats just to think about. So first of all, as of, I think this morning, there were approximately 82,000 cases worldwide and approaching 3,000 deaths, and that's what has been reported. And so if you just look at that, the case fatality rate is approximately 2 to 3% based on that number, right? Cases and the number of deaths. And I think the caution that we need to have is, remember that when we're doing surveillance, it's only the cases that have been identified with testing. And so that is sort of the denominator, if you will, from which the mortality data or the fatality data is being compared against. But in fact, it's well recognized that that is definitely a gross underestimate. So I can give you an example, which is related to, for example, the situation in Iran as an example. The number of cases that they have is a gross underestimate, or that they're reporting and they've identified by testing is a gross underestimate of probably all of the burden of cases. And the reason is just some of them, will be mild and not come to medical attention. And so it's hard to know with precision what the actual case fatality is. It's felt that it probably is an overestimate, not an underestimate, because there's lots of people that have non-severe and aren't tested. And even if you look at the situation in China, for example, they've even reached capacity on their testing and moved away from testing. And so we have to interpret the numbers with caution. What we believe is the majority of people have mild disease and mild symptoms. There's a subset clearly that become very severe where fatalities occur. And in large numbers, that subset can be a lot of people.
That, of course, is true. And there is a subset of people who are never diagnosed or suspected of having COVID-19 around the world who actually died from it and are never recorded. And I've said all along, getting bound up in our own numbers and case fatality and all the rest of it, like a lot of people are doing, is a misnomer. It is going to be in our communities. I would say it is now in our communities. It is highly infectious. You need to do stuff now to stop getting it. And if you get it, you probably will be fine, but some people will die from this. And enough people per 1,000 will die from this to overwhelm healthcare, to cause economic freezing and collapse and flat nothing going on for a period of months. And that's the risk. Not so much the personal risk of death from it, but the economic risks. And doing good hand hygiene, social distancing, buying all the food 3 or 4 weeks ago or a week ago or today if you have to, rather than waiting for this to actually break out in large numbers in your local community. Because by the time it breaks out in your community, you already could well be infected. There is a long latency period with this infection.
The Chief Medical Officer of Health has indicated that Canadians should be preparing for possible pandemic by stockpiling food, supplies. How seriously should we be taking this recommendation?
So I do definitely think that this is an opportunity, just as in, for any emergency, to be preparing and stockpiling food, necessary medications, any other kinds of items that are necessary, because there may come a point in time where you may be at home needing to take care of sick family members and may not be able to get out and get these supplies. In addition, a lot of people will be looking for gathering their supplies, and I think there's probably a lot of great resources online, Claudia, that you could probably direct the audience to, that could really give you that nice itemized checklist about exactly what it is you need for a short period of time versus an extended period of time.
I recommend 3 months, 12-week supply of food and toilet paper in your house now, including cleaning supplies and soap and hand sanitizer. All of that stuff you want to have in place before you need it. And worst case scenario, and this gets weak and goes away, and you spent all this money and time getting ready for this, make sure you bought food you actually like and elite, and then just eat it over the next 3 to 6 months and save some cash over that period of time. Doesn't harm you to have that amount of food in, doesn't take that amount of money, doesn't take that amount of space. I refer you to my videos, I refer you to lots of people's videos. She is saying here short duration events as opposed to long duration events. She's deliberately trying to get people not to look at prepper sites because we're crazy. Yes, we're crazy until we're not crazy, right?
Home kit for 72 hours of care or 72 hours of supplies that would be needed. However, we know that if you're sick or if you're home isolating to prevent further spread, you're looking at a minimum of 2 weeks to do this. So really think about that time frame and the essentials that you would need to make sure that you are okay and your family's okay for this. So prescriptions, definitely.
So that's why Canada's advising 2 weeks, because they want you to be at home and not leave for 2 weeks if you are put into quarantine. Now the thing of it is, we're not able to feed you or arrive at your house and give you stuff during that 2 weeks. So I think that's a really key and important point. If there's thousands, tens of thousands, hundreds of thousands, maybe several million or more than 1 million in a city been told don't leave your house for 2 weeks. That's worst case. I don't think we'll get to that in Canada, but you never know. They have in China and Singapore, I believe, and Italy, parts of it. You need to be able to feed yourself and not run out of toilet roll. We live in a society and a generation that believes I am really important, and I can pick up the phone and I can go, I'm out of toilet paper and I'm in quarantine, fix it! During a pandemic, nobody cares about you. Nobody will help you. It's about societal good rather than individual need. Get that into your heads. Get prepped. Get ready. If you have loved ones, elderly neighbours, etc., get an extra 2 weeks supply of food in for them and be prepared to drop it off at their door if they need it, if you wish to do that. We're going to have to work as a community in a local way to get through this, and we will get through this, and it will be fine. The stock market will go much lower if this gets bad, and my hospital believes it's going to get bad. Okay, so make the actions you need, get ready, brace, work together at a distance, and don't get too involved in people online with beards showing you shotguns. They're absolutely insane. They always have been and they always will be. They have nothing to teach you. They have nothing to give you. What you need to do is get proper advice and proper information from people that are sticking to the facts and the facts only. Well, this has been a long one. I was going to do a third part, but I thought people can't take this, right? People aren't able to watch the first parts of anything. This has been, I hope, helpful to you. If you've got any questions at all, please ask me below. I'll answer them if I can. If I don't know, I'll try and find out. And if I still can't find out, I'll say, don't know. There's a lot of known unknowns with this. We're all going to be fine. Very few people are going to die. It's not the end of the world. This is not Armageddon. This is not the end times. This is not the unsealing of the seventh trumpet or the sheep or whatever it is. Take care, be happy, and enjoy yourself. Doodles. So far the terriers are completely unaffected by it. This has been a Bad Terrier 2020 production. Definitely go for a walk today.